India's largest state's capital, Jaipur, popularly known as Pink City, surrounded by the world's oldest mountain range, Aravalli. It is renowned for its perfect blend of wealthy heritage combined with its imperishable bygone past and cosmopolitan culture. It is recently inscribed as a World Heritage Site by UNESCO. Apart from being the administrative center of the state, Jaipur is the most preferred medical destination. Eternal Hospital Jaipur emerged as an eternal bliss for mankind across the globe. Founded in the year 2013 in Jaipur, Rajasthan, as a heart care center, which later emerged as one of the most preferred multi-speciality centers in North India by Mrs. Manju Sharma, co-chairman and managing director, and Dr. Samin K. Sharma, chairman and chief interventional cardiologist, based at Mount Sinai Hospital, New York City, New York, USA. He's also known as Master of Rotabilitator. He believes the hospital is driven by a single thrust to provide the best standard in patient care through human resources, infrastructure, and technology.
ईएचसीसी हॉस्पिटल अपने आप में एक डिफरेंट तरह का हॉस्पिटल है। ये अस्पताल शुरुआत में सिर्फ कार्डियक केयर के लिए स्टार्ट हुआ था, जैसे कि इसका नाम है एटर्नल हार्ट केयर सेंटर। लेकिन धीरे धीरे यहाँ के माहौल में ऐसा परिवर्तन आया कि यहाँ पे सुपर स्पेशलिटी में ऑर्थोपेडिक्स, न्यूरो साइंसेज, गैस्ट्रोएंटरोलॉजी, गायनी, लेप्रोस्कोपिक गायनी, ये सब जुड़ते चले गए। और समय दर समय एटर्नल अस्पताल ने इतनी ज़्यादा प्रगति करी कि आज की तारीख में ये सुपर स्पेशलिटी में राजस्थान का नहीं, आसपास के प्रदेशों का नहीं, रादर कंट्री में नाम रखता है। तो हार्ट के मामले में तो ये इंडिया का सर्वोत्तम अस्पताल माना जाता है।
Eternal Hospital is the premium healthcare hospital focused on delivering the highest quality care with a 250-bed capacity spread over 5 floors. All construction and adaptation of technology have been done in adherence to international norms. The top-performing medical professionals in various specialities, highly trained nurses and paramedical staff from across the globe. Center is known for many firsts, procedures and surgeries in the world, India and Rajasthan. Some procedures and surgeries are TMVR surgery and double valve implant, MyValve TAVI valve implantation, leadless pacemaker, infrastructure. Here, doctors have access to sophisticated equipment to provide quality care round the clock. The latest range of equipment ranging from highly equipped ICUs to FD20, most advanced cath lab in Rajasthan, radiology department, path lab dialysis center, wellness section, etc., which are patient-centric, ensures accountability and transparency, which help doctors to give committed time to each patient. Patient rooms at Eternal Hospital are designed to ensure complete patient comfort, which further bifurcated into the suite. Super Deluxe and semi-deluxe rooms on twin sharing basis with all possible amenities. Multi-speciality. Eternal Hospital brings the best in over 15 multi-speciality treatment to the state of Rajasthan owing to exclusive services and specialities like cardiology, cardiac surgery, neurology, neuro surgery, critical care joint replacement, spine surgery, nephrology, urology, and many more. It also offers unique services like nuclear medicines, infectious disease department, fast-track surgeries, preventive health department. Our centers of excellence. Besides excellent results in cardiac care, the hospital also offers endocrinology and diabetics, gynecology and obstetrics and IVF, lab medicine and pathology, pulmonology and urology. Apart from these, Eternal Hospital offers tertiary care, namely cardiac sciences, neurosciences, renal sciences, orthopedics and joint replacement, critical care, internal medicine, and many other specialities supported by a highly competent team of doctors and medical staff. The center has dedicated 7 operation theatres, state-of-art ICUs, blood bank, comprehensive path lab, sterilization room, 𝐒𝐲𝐿 6000, biochemistry analyzer,
So good evening. Good evening and welcome to all in today's evening symposium organized by Eternal Hospital Jaipur on complex coronary intervention. So as you know, Eternal Hospital is the most preferred multi-super specialty hospital of Rajasthan. And Eternal Hospital is also accredited with Joint Commission International, and it is the highest international benchmark available worldwide. And we are the only hospital in Rajasthan who got JCI accreditation. So apart from JCI, our hospital is also having knowledge sharing arrangement with Mount Sinai Hospital, New York, USA. And most preferred center for American College of Cardiology. So again, on the behalf of Eternal team, I welcome you all. So of course, physicians are at the forefront when it comes to treating coronary artery disease, the blockage of heart arteries due to cholesterol buildup, with the latest treatment and therapies for complex coronary intervention. This platform offers everyone present here and learning opportunity along with interaction with highly experienced clinical team. So let me first introduce Dr. Sanjeev Sharma sir, who will further introduce Dr. Samin K Sharma sir, and sir has just joined from New York, USA. So give a big round of applause. Samin sir has also joined us. So Dr. Sanjeev K Sharma sir did MBBS MD with gold medalist from SMS Medical College, Jaipur. DM Cardiology from AIIMS, New Delhi, Fellow of American College of Cardiology, Fellow of European Society of Cardiology, Fellow of Society for Cardiovascular Angiography and Intervention, and he is presently serving as a Director, Interventional Cardiology at Eternal Hospital, Jaipur. So he is having overall clinical experience of 20 years, in which he got an opportunity to serve in some of the top hospitals of the country. His area of interest in complex coronary intervention, structural heart intervention, which includes rotablation, IVL shock wave for calcified coronaries, left main intervention, post-bypass intervention, CTO intervention, imaging, guided PCI, OCT IVAS, PCI with LV support Impella, transcatheter aortic valve replacement, and transmitral valve replacement. And Dr. Sanjeev sir has been awarded the prestigious Rajasthan Gaurav Award for his contribution in the field of cardiovascular medicine and cardiovascular intervention. And he has been regularly invited as a faculty by top national and international cardiology meeting to share his immense expertise. He has been actively involved in teaching an academic program at Eternal Hospital, Jaipur, and has an additional responsibility of Director, DNB Cardiology Super Specialty Program at Eternal Hospital, Jaipur. He is also a course director of Eternal Heart Conclave since 2015. So now I will request Dr. Sanjeev Sharma sir to introduce Dr. Samin K Sharma sir. He is our chairman and very well-known, world-renowned interventional cardiologist. So I will request Dr. Sanjeev Sharma sir to further introduce Dr. Samin sir. Thank you.
Thanks, Nitesh, for kind introduction. On behalf of Cardiac Sciences Department at Eternal Hospital, Jaipur, I welcome you all. So in spite of very heavy rain this evening, you all made it possible. It's nice to see such a in a good numbers, all the physicians have come. And as you know about the theme, it's all about complex coronary intervention in 2022 and what latest technology we do have all over the world. Dr. Samin sir will be sharing, and also from my side, the same state-of-art technology we do have in our Eternal Hospital. Let me introduce Dr. Samin Sharma sir. Sir is well known to all of us, not only in our country, but all over the world. He's a master operator in terms of coronary intervention, also for the structural heart intervention. And he has been doing the highest number of intervention in the state of New York as an individual operator and as a Department of Cardiac Sciences at Mount Sinai, New York. And his area of expertise is all sorts of complex coronary intervention, and he has been known as a master operator in terms of rotablation all over the world. And he is also expert in the complex structural heart disease, which includes your transcatheter aortic valve replacement, transcatheter mitral valve replacement, and other structural heart procedures. And Shah has been conducting various academic activities and annual programs in New York and at other places on a regular basis. With those words, I would like to invite Dr. Samin Sharma sir for his talk on left main coronary intervention in 2022 updates.
Okay, Sanjeev, thank you very much, and our doctor colleagues and all the members who are there. Greetings, first from the Eternal Hospital and from Mount Sinai, New York. And being, as Mr. mentioned, not a great weather, but we always, our educational initiative continues. And I'm so thankful to all of you to be there and the organizers of this evening event. Clearly, we want to bring the latest to you. Purpose of that, these educational exercises, just to know and update everyone that what is there and what can be, what is being done at present, not only locally, nationally, as well as globally. With that task, we have selected two topics: complex coronary intervention, what to expect in 2022, will be delivered by Dr. Sanjeev Sharma, and he'll, more important, will show cases. You know, not much theory, but some theory has to be, but more important type of cases being done. And I'll talk about update in left main revascularization in 2022. With that note, if it's okay, we start sharing my slides, and let's just see everything is working. Okay, so everybody can see the slides well, and can you hear me well also?
Yes, sir.
Okay, beautiful. All right. So that's my task for next 20 minutes or so about left main disease revascularization, where we are this year in 2022. So basically, what is the left main? Left main is the main artery of the heart, as you know, which divides into two, circumflex and the LAD. And some cases we have ramus, so it could be trifurcation. And where the blockage usually occurs, majority at the distal end, which is bifurcation. And there's a whole physiological reason for it, because high turbulence, high flow increases the plaque accumulation, rupture, and lesion here. Sometimes there is osteal, rarely in the body. So that's the left main disease, which occurs in about 4 to 8% of cases which come to the cath lab. And what had been the issue is the distal part of the left main. That is with the very troublesome in terms of intervention in the past, although now we have various techniques which I'm going to speak about, but clearly the distal left main bifurcation is the one which is associated with bad outcomes on long term. And sometimes it is a trifurcation, as I mentioned, 3 branches. And over the years, I would say that back in 80s and 90s, early 90s, all these patients were sent for bypass surgery, Cabbage, because left main was a disease for surgeons. So this, and then why that came up? Because we did the trials. The trials were early time, there are three of them, VA, European Cooperative Society, and CAS, all showed that Cabbage did better than medical therapy. You say, why not was PCI that time? Remember in 70s, there was no PCI. It was only against medical therapy. So clearly, the Cabbage was superior to medical therapy. So overall has been shown that the overall about medical therapy, there is about 15% mortality of the left main disease on medical management. So it became gold standard that every patient is sent for bypass surgery, particularly those who are otherwise viable. And this actually is the historical background. Over the years of which we know, some cases of the balloon angioplasty were done early time, but the various trials showed, as I mentioned, Cabbage versus medical therapy, and all were positive. But then in last, I would say about 20 years, the PCI has emerged as a viable option, particularly not in all, but selected cases in the beginning. And then we have now the randomized trials, and I'll discuss briefly about them. We're comparing Cabbage versus stenting for left main disease. So these are the various trials which are shown here. But the point is, initially was Cabbage superior to medical therapy. Then we are comparative trial, Cabbage versus PCI, and many of them are equivalent, and I'll show you the data even long term. So therefore, what has happened? Based on those guidelines, about those data, the guidelines have emerged. That is, that guideline class 1, Cabbage, and PCI is 2A or 2B. What does that mean? That if patient is very high risk for surgery, PCI could be done. That's a 2A. It's not a randomized, so not a class 1. And the 2B, the patient, that some you can also offer alternate to bypass surgery. And of course, the medication, the medical therapy is class 3. So any patient with a left main disease, if we say, well, we are going to try medical therapy, that's a wrong thing to do. This is against the guidelines. Why? Because there is about 15 to 16% mortality per year in the medical therapy group. So what does that mean? That you need to do something about once you find the lesion in the left main, whether you do a bypass surgery or stenting. This is actually a very nice review article in JACC on the left main coronary artery disease, secular trends in patient characteristics, treatment, and outcome. The previous slide is from there, that how we are doing, majority of our patients are undergoing revascularization and not the medical therapy. So what I'm going to do is going to show you two cases where the actual decision came that which patient should do better with the bypass surgery and which patient is appropriate for stenting. So this is the patient, case number 1, 73-year-old patient, had a shortness of breath, had a stress test which was positive for LAD ischemia. It's a diabetic patient. And of course, other factors, so always they have various risk factors. And good medical therapy was taken and was sent for cardiac cath. So now you can see here, this is we are giving an injection. This is the trifurcating left main. Remember I said about 10% patients could be trifurcating, though not only 2. This is the left main disease here, circumflex, LAD, and the ramus. So there is a trifurcating left main disease. In addition, there are additional disease in the branches of the circumflex on this side. And then this is the LAD, the additional lesions in the left anterior descending. And the right coronary artery has just mild disease, except distally in the PDA. Ejection fraction, that is how good the heart is contracting, was normal in this particular case. So what we found it basically, this is the diabetic patient with 3 vessel and left main disease. And what we do is each lesion, nowadays people say, well, how can you quantify the blockages? That we have the numerical numbers where the blockage is, whether it's a calcium, bifurcation, lesion length, comes up with a syntax score. So anything syntax score of 22 and below, we call it a low syntax score. 23 to 32 is intermediate, and 33 and above is a high syntax score. Higher the syntax score means there is a more disease burden, and those are the patients do better with the bypass surgery compared to stenting. So this case has a syntax score of 33. Now this is one case. Now let's go to the second patient, 74-year-old, also a chest pain, and CAT scan CTA in this patient showed 1 vessel disease and some left main. Remember, once you had high calcium, you may not be able to evaluate or really report that how bad is the lesion, because of calcium prevents the CT good analysis. This patient also has a risk factor, and patient is on good medical therapy and came here to the cardiac cath. You see here, this is the distal part of the left main, and there's additional disease in the LAD. So clearly, this is the circumflex, which is good, distal part of the left main, and the LAD in the mid. And then many times to look inside the artery, that truly it is a plaque. There are numbers that if your left main, the inside lumen on the imaging, which is what being done here with the IVUS, anything less than 6 millimeters square means it's a significant left main disease. In this case, in various areas was 3.92, and LAD was anything less than 4 for the anterior descending is significant. The circumflex was more than 5, so clearly it was a blockage only on one side from left main to LAD, additional disease in the mid LAD. So why we do intravascular ultrasound? Because some studies have shown that doing imaging at the time of stenting, if you decide, gives you better outcome on long run. So having said that, these are the two patients. So what is the advantage and disadvantage of the two techniques? So clearly we understood. Left main, no medical therapy. Either you do a PCI or you do bypass surgery. So basically PCI, less invasive, low comorbid conditions, or we call morbidities in the hospital, less bleeding, less kidney injury, less atrial fibrillation, shorter hospitalization, lower procedural risk of CVA, and faster recovery and quality of life. Patient can get back to work. The Cabbage advantages are more complete revascularization, fewer repeat revascularization, and better protection against future MI. That is spontaneous, because that has been shown in many studies. Because what it does is bypasses the proximal lesions, which usually rupture and causes spontaneous MI and death. And therefore, many of the studies have shown that Cabbage saves life by preventing future myocardial infarctions and so. So this is basically the pro and con of both techniques, the PCI and the Cabbage. And clearly one is faster, maybe require repeat intervention, and the Cabbage is more durable. But yes, it requires the initial higher comorbidities, and recovery is definitely delayed. So this is basically just to put it together again, that what the data showed, medical therapy versus Cabbage, and again in the recent time, those were the early data. So now from 1995 to 2013, even then you see here that medical therapy group, whatever we decide, has a high mortality. For some reason, usually patients goes to medical therapy because they are high risk for both PCI or Cabbage. So this is just to say that Cabbage and PCI were identical. This is the data from the British Society, European Society, and to show Cabbage and PCI were equal, and medical therapy has higher problem. And the factor, this is what was mentioning, that if you have more higher syntax score, that event rate definitely increases, and it favors bypass surgery compared to PCI, because event rate is lower in the Cabbage group compared to PCI group. And same also with the diabetics, that lower event rate in the diabetic compared to the PCI. So then we actually had done the long-term follow-up of these patients also. So overall, if you talk about the mortality only, the identical at follow-up, these were our early 11 trials of the PCI versus Cabbage. Of the 11,000 patients, of them 39% were left main, and at 5-year follow-up were identical in terms of mortality. Now we have selected trials in the recent time, I would say that in 2010 plus, the Syntax, Pre-Combat, Noble, and Excel. So all of them showing from mortality point of view, identical, except the Excel trial did show higher mortality with the PCI at 5 years. So this field continues to evolve, that whether PCI is harmful patient with the left main compared to bypass surgery, but overall consensus from the latest meta-analysis, which I'm going to share with you shortly. Now, this is the Excel trial. This is where the whole controversy, this is a contemporary trial of a left main where the syntax score was less than 33, and they were followed for 5 years, PCI versus Cabbage. Overall endpoints were similar, but there was, as I mentioned, slightly higher death rate in the PCI group compared to Cabbage in this trial. And of course, what is also we have seen that Cabbage group have a higher stroke rate compared to PCI. So this field of a higher stroke rate has been shown by many other studies after the bypass surgery, which you are very well aware. The myocardial infarction in the trial was not different, and the graft occlusion. So clearly, once you do the bypass, there is a occlusion of the graft versus stent thrombosis. This actually, from the Excel trial data showed that stent thrombosis nowadays is a very rare event, less than 1%. But you have actually the graft occlusion can occur in 2 to 4% of cases. So this basically is that once you try to do, you do a complete revascularization, and imaging, which I mentioned, that put a imaging into equation when you do a PCI of the left main, they have a better outcome at follow-up compared to no imaging group, 8.9% versus 12.9 if you did not do imaging. So clearly, anytime we as an interventionalist, Sanjeev, I know that you're very meticulous about it also. Once you do a stent of the left main, we image to make sure the stent is doing its job. Now, this is the latest one, which I'm alluding earlier. So this is the latest paper in the Lancet by the Brownwald, who is one of the lead author in this paper. They compare all the trials of the left main, the Syntax, Pre-Combat, Noble, and Excel, and gave a data up to the 10-year follow-up of 4,400 patients, and basically showed that at 5 years, there is only 1% higher mortality with the PCI versus Cabbage. So overall, what if we had to tell the patient, so what is the difference you do PCI versus Cabbage is 0.2% per year. 0.2% per year, it will be higher mortality. So overall, it was not significant. And if the 10 year is about the same, you can see here, 5 year, the difference was 1%. At 10 year, difference was 2%. So clearly 0.2% per year. Now, overall stroke rate is lower, and there's slightly higher myocardial infarction and the repeat intervention is higher with the PCI compared to Cabbage. So that basically is the word that most complex disease, Cabbage is better versus PCI. High syntax score, Cabbage is better with the PCI. And these are the other individual endpoints which favored PCI versus Cabbage in some areas. So let's come back to the point. So we learned that patients with a more complex disease, even at this time, do better with the bypass. Patient with a less complex disease of the left main do very good with the PCI. So this patient who had a trifurcating left main, whom we did, the syntax score was 33 and diabetic. We did an IVUS, the lumen was 4.8. That basically means significant. Remember, left main lumen, 6 millimeter is more than 6 is good, less than 6 or maybe even 5.5 is bad. It was 4.8. So this patient appropriately was sent for bypass surgery. And this patient had Cabbage times 4 with a Lima to LAD and did subsequently very well. The second patient who had a syntax score of low of the distal left main and the LAD lesions, calcific, so had a 2 rotabur, 1.5 and 2 over because of calcification. And then the 2 stents were implanted, one in the mid LAD, one in the left main. And then if you actually, the side branch remains okay, you don't even have to open it up, which we call kissing balloon inflation if it's compromised, but this patient did very well. So one case Cabbage, and this is the case with the PCI. And this actually, once you do PCI, you confirm by the IVUS. I showed that data are clear that once you do imaging guided PCI, you have a better outcome, short term as well as long term. So what you're trying to achieve is more than 8 millimeters square. And here we achieve 9.6. And in the LAD, in the area, you want to achieve more than 4 millimeters square. And this actually was 7.7 and 5 millimeter further. So just to sum up, when we as an interventionist are trying to do a PCI of the left main, we require few, I would say, the strategies. The key is you have to have a right guide catheter and our devices, and particularly if they are more complex patients who are low ejection fraction, then we use some hemodynamic support of the impella or balloon pump. And of course, a small amount of dye, and as you mentioned, imaging. Then during the procedure, you do your best stent technique, and then adjunct pharmacology. So key is that anytime you're performing the left main intervention, you want to make sure patient's going to take a dual antiplatelet therapy for at least 1 year, if not longer. So those cases, we try to use more stronger antiplatelet therapy beyond just clopidogrel, either prasugrel or ticagrelor, and of course, additional guideline-directed medical therapy of statins, beta blocker, ACE inhibitor, and PCSK9 inhibitor now. And then key important is that you have a correct planning and selection of the case. So complex case, you have to discuss. We had always discussed like with Dr. Bana, and so they are appropriate patient with a complex CAD, high syntax score will go for bypass. They'll do better with bypass surgery. But less complex, clearly you plan with a PCI and so. So what has happened over the years now, in the past, when the Cabbage, there used to be a gap between the Cabbage and PCI. It favors Cabbage. Now we learn, as I shown today, that many, with our technique of the PCI, in not less than high complexity, the PCI does equally good than compared to Cabbage. So these are basically still remain the guideline that PCI has not become class 1. Of course, in the low syntax score, yes, like isolated lesions and so, others still remain 2A or 2B, as we have mentioned. And the second point, once you detect left main, even if patient is asymptomatic, those patients should be treated. You cannot leave left main to the medical therapy. So that's a very, very important point. Even asymptomatic left main should be treated once it is diagnosed. So this is just to sum up my last slide, basically, which I'm putting together. Where do we stand in 2022? PCI, Cabbage. Clearly, these cases should have heart team discussion with a cardiologist, our referring physician, as well as the surgeon. And then PCI, we know the less invasive, early safety advantage, and the lower periprocessal event. And we also learned it has similar mortality. Cabbage, long-term durability, less revascularization, less spontaneous MI, and similar mortality. So what will favor PCI versus Cabbage? So this is where it remains. That which case then you'll favor PCI more for Cabbage. So PCI, patient need urgently, acute MI. Patient have high comorbid condition, bad stroke, and so. And then patient with an anatomical factor, simple anatomical factor will favor PCI. Now, Cabbage will be patient with a low ejection fraction, need additional valve surgery, patient who cannot take the depth for a long time, and more complex disease will do better with the Cabbage compared to PCI as shown here. And then after we are done, we still need to do optimize that in the PCI group, you do imaging, decide 1 or 2 stents, you have to open all the blockages. And of course, for the Cabbage group, arterial revascularization, off pump, early mobilization, all will continue to improve the outcome of these left main patients. And thank you very much. I'll stop here. And I can take any questions from our audience and podium.
In the last slide, we lost connection. Can you summarize the last slide first?
Okay. Okay, let me get to the last. We have shared it now, right? Good. Okay, so let's just to sum those to final points. So I probably left it here, right? This basically means that it still remain the preferred, particularly highly complex disease Cabbage remain class 1 indication. Now, which case can you do PCI? Can you see the slide now?
Yeah, we can.
Okay. Yeah. So PCI can be done in simple cases as per the guideline, because we still need some more data to make it in intermediate syntax score. That's the key. But yes, patient who has Cabbage, who are high risk because of anatomical conditions, COPD, and medical conditions, COPD, stroke, they do better. Will be with the PCI, because Cabbage will be high risk and so. So our second point I wanted to make, that once you detect left main, whether patient has symptoms or not, those patients should be need to get revascularized, whether by Cabbage or PCI. And criteria we have said, simple to intermediate risk, they do better with the PCI, or they do equally good with the PCI compared to bypass. But if more complex disease, they should go for bypass. So this is the one I wanted to put it together, that advantage and disadvantages of both, or where we select what, PCI and Cabbage, which we already discussed. But more important is which patient, based on the clinical and anatomical factors, will lead to one versus other. Acute MI, urgent revascularization, serious comorbid conditions, this patient will favor PCI. Although patient with a low ejection fraction, diabetic, need for concomitant valve surgery, and maybe patient who they cannot take DAPT, because DAPT is very essential in the left main stenting, because they stop it, patient could have a trouble, could die even because of stent thrombosis. So if there is a question for some reason, patient will not take DAPT, those patients will do better with the Cabbage compared to PCI. Then the anatomical factors, that is simple, straightforward, low syntax score, good for PCI. Patient with a more complex disease, bifurcation, or additional vessel disease, and so high syntax score will do better with Cabbage. And then, of course, after all is done, that we need to optimize our results. And the results basically is, once you do PCI, there are blockage in both the branches, you use 2 stents. And imaging, long-term DAPT therapy. And in the Cabbage group, arterial revascularization, off-pump surgery, early immobilization, all will help to improve the overall outcome of the left main disease.
Thanks, sir. It was a great overview about the left main intervention. The important points you highlighted: number one, the patient with a low syntax score, the angioplasty and bypass are equally acceptable. When there is a high syntax score with a more complex disease, bypass scores over the PCI. Number two, in a diabetic patient with a left main distal bifurcation or the multivessel disease, CABG is superior to angioplasty. So diabetic population, high syntax score. And third important point is, whenever you do a left main PCI, always do imaging. Imaging by intravascular ultrasound or OCT, that improves the outcome, not only acute, but the long-term outcome. So it's important to integrate imaging while doing intervention for the left main bifurcation. And the next thing is, if the patient is having other comorbid conditions like LV dysfunction, then also the CABG scores over the PCI. The surgery offers more complete revasc, more grafts to all the vessels, small and large. So it really helps in improving the ejection fraction in the long term. So high syntax score, more complex disease, diabetic population, LV dysfunction, the CABG scores over the PCI. And so this is a great overview. So one question is, the patients and families' choice, does it really matter? Because it's a hard team scenario. In spite of having complex disease, left main distal bifurcation, these days, many families, they want to go for the PCI in spite of having high syntax score. So what's that percentage in your practice in New York?
Very good point. So with the group of patients which we have spoken, multivessel diabetic with a high syntax score, you have to take them out of the cath lab and then have a discussion with the family, physician, then cardiologist and referring physician, many of them like in the audience, and along with a surgeon. So then you present the data. So this is what we think, but I can tell you half of them, about 52% of those patients, when we recommend as an interventionist, say you should go for Cabbage, almost half of them will say, no, we don't want to go for Cabbage, even if we have to come back, as long as I'm not going to die during PCI. And we know that nowadays we have such a good equipment and support devices, the death on table, if not acute MI, is extremely, extremely rare, maybe 0.1%, 0.2% maximum, 1 in 500 to 1,000. So very, very rare death on the table. So as long as that issue is taken care, people say, well, I can come back few times, but I want a PCI. So that is fine. So that the guidelines do say the ultimate decision is the patient. But you need to tell the patient in a more controlled environment, not on the table when patient is lying that, you know what, your PCI we can do quickly and Cabbage will be that complex. No, patient with a complex CAD has to come out of the room, have a discussion with the surgeons and the cardio and referring physicians and with the family, and then make a decision. So a patient decides is the ultimate decision maker. No matter what we say, we have to honor the patient wishes. Very simple, I tell, because if we don't do it, they'll find somebody who will do it. So clearly, as long as you are done by the guidelines, your heart team discussion, you offer the patient what it is, patient still says, no, I want to go for PCI, it's completely fine. It becomes like class 1 indication at that time. And that number is almost 50%. And that is basically to say that despite us, based on the data, we're telling the patient, go for Cabbage, and they do not go for Cabbage, is 52% at Mount Sinai.
So that's a great point. In spite of telling them that it's a complex disease and you deserve bypass as a first choice, still patients and family, they opt for the PCI. And we have been able to give the best results in those scenarios also. With the advancement of technique, because if there's calcified, we use a rotablation, orbital atherectomy, or the IVL. We use imaging and do a latest generation stents. So outcomes are good. And this is there in the US and also in India. In spite of being complex disease, patients would like to go for the PCR because it's less invasive, early recovery. And we've been seeing it's a good outcome. It's not like they're having short-term events and all. They're doing good in the long term also. So
and that's an important point. So all these trials also have shown that in hospital events, I mean, not in, but like 30-day events of MI, stroke, and all, and mortality even significantly lower with the PCI compared to Cabbage. Cabbage really starts having an advantage after 1 year and plus. But short term, if we know that patient's lifespan is limited, patient 85 years of age and so that definitely patient should go for PCI, not for Cabbage, irrespective of the lesion locations and complexity and syntax score. So key is short term, there's no question PCI is better. But only question is those who have a good lifespan of 5, 10, 15 years, what has been seen that in complex disease, PCI loses to bypass surgery in those cases. But if it is less complex, outcomes are identical, except repeat revascularization, that you have a little more chance of coming back after PCI compared to bypass surgery.
So, and one situation is when surgery is turned down by the surgeons. Like, my talk is all about that single case I am moving around with the same kind of scenario. Patient is 86 years old, multiple comorbidities, diabetic, hypertensive, CKD, LV dysfunction, and is be seen by the number of cardiac surgeons and interventionists. They have turned down all the intervention, and patient is coming again and again with the symptomatic heart failure. Then we have to do something, and that too with the heart pump support. And that is an extreme risk scenario when surgery is contraindicated or they turn down. We have an MPL or heart pump support to take care of those patients. Otherwise, there was no other option but the medical therapy and very short lifespan for those patients. Now you can revascularize with the heart pump support and give them a good quality of life. And your point about it.
Absolutely. Yeah, no, that is the key, is that intervention now can be done almost in everyone. So let's say back in early 90s, the left main for PCI was taboo. That patient will die with a PCI that time, but no longer that scenario now. We can take the patient out of the lab safely. Only question remains in the long term. So clearly, if the patient needs it, based on the acute situation, we have the support devices, we can take care of the patient and give quality of life, at least for short term, but even in the complex cases. In the less complex cases, good quality of life for a long run.
So thank you very much. Let's move on to the next because it's already 9:50. So I'll be give an overview in the next 15-20 minutes time. It's a case-based scenario, so you'll really going to like it and understand it better. So my topic is complex coronary intervention, what to expect in 2022. As we all know, we are having a more frequent occurrence of patients coming with the calcified disease, multivessel disease, left main bifurcations, left main trifurcations, patient with the LV dysfunction, ejection fraction 30% or less, All these patients are coming for the interventionist because either surgery is turned down because of its extreme risk scenario. And we are also finding the multiple comorbid conditions like advanced age is 80, 85 plus. So the surgeons don't want to take it. Having a long-standing diabetes, hypertension, on complications of diabetes and hypertension, like peripheral artery disease, carotid disease, and also stroke. So these patients are not being taken up by the surgeon. And then what best we can offer from the intervention point of view. So when we talk about the complex coronary intervention, what we exactly need? We need a good team of expert interventional cardiologists. Second is a cardiac anesthetist. On all the intervention in our hospital, we always, whenever there's PCIs on table, we say go for the PCI, immediately anesthetist joins us. So anesthesia backup is very important. That makes you very comfortable. You can focus on your job, and all the hemodynamics and all the fluctuations can be taken care of by the anesthetist. So there should not be any delay. If there's a desaturation, they can put a BiPAP. The patient require ventilation, can be immediately taken care. So cardiac anesthesia backup is very important. Expert interventional cardiologist team is very important. Third is the equipped cath lab. So cath lab should be equipped with for the everything. Like for the calcium management, you can have a cutting balloon or scoring balloon or the rotablation or the IVL. And for imaging, you should have an IVUS OCT. Like in the next slide, the same thing I am summarized. We need to have all the modalities for the calcium management. We need to have a cutting balloon or scoring balloon we use when there's an arc of calcium is less than 180 degree. Like it's a 360 degree. If it's a 180 degree, you can manage with a cutting or scoring balloon. If it's a 360 degree, then we have to use a rotablation for the superficial calcium. And for the deep calcium, we can use a IVL or shockwave. IVL is an intravascular lithotripsy. Lithotripsy we use for the kidney stones and all those stones. The same technology. We have an IVL balloon, which we position at the site of calcium. And then we push the button and the ultrasound waves are released from that balloon at multiple level, and that breaks the calcium. So aim is to break the calcium so that stent can expand fully. That is the IVL or shockwave therapy. This is for the deep calcium, and for the superficial calcium is a rotablation. Sometimes a very critical lesion, so nothing will pass through. So you cannot put your IVL balloon. You have to do a rotablation and ablate the superficial calcium, and then you can put a IVL balloon and crack the deep calcium. So these are the calcium management modalities, and the other modalities are cutting a scoring balloon for the less severe calcium. Other important point to highlight is the imaging is a must. Whenever you deal with a complex coronary intervention, whether it's a calcified or it's a long segment disease, you need to have a correct characterization of plaque characteristic, whether it's a fibrotic or fibrocalcific or the heavy calcium, and whether the calcium is superficial or deep, and how much is the length of calcium, and how long is it's an arc of calcium. It's a 360 degree or 270 degree or the 180 degree. On the basis of that, you can decide what modality is best for the calcium management for that particular patients. So imaging is a must. Whenever you talk about the left main intervention, as Dr. Samin Sharma pointed out, you should end up with the intravascular imaging, whether you have done a good job. So how good is a stent expansion? Whether stent is underexpanded, then you have to inflate with a bigger balloon and optimize the result. Otherwise, you can have complications. Why these days we are seeing less complications, less in thrombosis? Because of more optimal deployment stent, because of using the technology like calcium management, and also using imaging for proper optimization of stenting. Now, next is the Cto Toolkit. It's a chronic total occlusion toolkit. For chronic occlusion, we need to have different kind of a guide wires, different strength of. There's a hard wire, there's a 4 gram, 8 gram, 12 gram. This is a strip strength, how we can drill that chronic occlusion. So you should have all the types of wire with you, and also different devices like cross boss or stingray. These are the penetrating devices to cross the CTO. So this should be available in your cath lab. And next one is the large bore access, because all these complex intervention required a large bore access, like 12 French, 14 French. So you should have devices to pre-close or post-close. Pre-close means once you dilate the arterial with your sheath, then you can first put a pre-glides. You can put a pre-close suture devices, and then you can put a 12 French, 14 French, do your procedure, take it out and suture it. So the device closure is very important in managing those groins. Earlier, there used to be surgical cut down. For the bigger bore sheath, you have to surgically close it. Now you have closure devices. And the most important other fact is LV support. LV support is very important. Whenever you're doing a complex intervention in a background of cardiogenic shock or a patient with severe LV dysfunction, you should have LV support devices. The device which you all are aware of is the intra-aortic balloon pump. That is there for more than 20 years now, but it hardly supports. It just gives a 1 to 1.5 liters per minute of support. These days, we do have an advanced heart pump support like Impella. Impella is a rotary pump which sucks the blood from the left ventricle and ejects into the aorta, thereby maintaining cardiac output and maintaining, it gives a relief to the operator. Operator can do all the complex work while and the cardiac output is being maintained by the Impella heart pump. And that is a different 2.5 liters, for more complex, we can use a 3.5 liters and up to 5 liters we can use. And right side Impella is also available, but it's an expensive device to use. So let's start with the case-based learning. I just have one case with multiple learning points. This case is I'll tell you first, this case I performed on the 8th of July. So it's a 2 weeks old, a very fresh case, fresh in my memory. It's an 85-year-old male who has been diabetic and hypertensive for the last 30 years, chronic kidney disease, and had an inferior posterior MI in the month of February 2022. An ejection fraction 30-35% and moderate mitral regurgitation. And he had a moderate pulmonary arterial hypertension because of LV dysfunction and mitral regurgitation. PA pressures were in the range of 50 to 55. And he was in sinus rhythm. So this was in February 22, and he presented with the ischemic LVF. So we stabilized him, decongested, put him on antiplatelet statins and the diuretic, lungs are clear. Then we subjected him for diagnostic or angiography. An angiogram revealed heavily calcified distal left main bifurcation. It was a left dominant circulation, calcified distal left main bifurcation, and also the long segment disease in the circumflex distally also. So this is an ideal case for the bypass surgery because of diabetes, because of hypertension, because of LV dysfunction, and because of extensive calcium and the multivessel and distal bifurcation, distal left main disease. But the issue is 85 years and multiple comorbid conditions. So two modalities. Either we go for the high risk Cabbage, or because of LV dysfunction, you need to have heart pump support like Impella, or the IBP. IBP is tricky because there's a ischemic LVF. The patient is going to tolerate it or not. So we need a heart pump support with the Impella. On that support, we can do a rotablation and IVL, and then put a stent. So these are two options available. Patient family opted for medical therapy. They'd gone to a number of interventional cardiologists, cardiac surgeons in our hospital and outside Jaipur. They had gone to Delhi also, all the top centers of Delhi. And all of them suggested that you better try with the medical therapy because of advanced age and multiple comorbid conditions. But the fact is, the patient got admitted twice over the next 2 months' time. And every time he come with a ischemic LVF, borderline hemodynamics, saturation borderline, we used to admit, put an intra-aortic balloon pump, decongest, and discharge. This time he got admitted on 24th of June. And the condition was, he was in a state of cardiogenic shock. BP was 85/50. The normal BP for him was 130/80. But he came with a shock-like condition. To my OPD, he was just like gasping. Saturation was 85%. He was immediately rushed to emergency. ABG was done, lactate was 5. Immediately started on vasopressors, NORAD infusion, put on a BiPAP, non-invasive ventilation, started on vasopressors, and immediately intra-aortic balloon pump was put. So hemodynamic support, oxygen, and heparin. This was the ECG in the ER. This is in the evening around 5:30 or 6. You can clearly make out there is a ST elevation in the AVR and V1, and there is a 7 to 8 millimeter ST depression in the precord leads. This clearly suggests there is a big area of myocardium geopathy, or you can say as just like a left main equivalent ECG. And there is a bradycardia. Bradycardia is an ominous sign. Patient in shock with bradycardia and having these kind of EKG changes, they have short mortality if you don't do anything immediately. So patient was put on IABP, stabilized on intra-aortic balloon pump, vasopressors over the next 4 to 5 days, but family opted for medical therapy. They don't want to go for anything. So when we started weaning the IABP on day 6, the patient again started decompensating. And then again, the pressure started falling and there was a tachycardia. And the patient also developed stroke. He had right MC artery stroke. There's a weakness on the left side of the body. Immediately, neurosurgical consultation was done. Again, intra-aortic balloon pump was put from the opposite groin. So within 24 hours. And then neuro consultation was done. And on this, we discussed with the neurologist. It's not possible to take him out of ICU unless we do something for this. We need to revascularize. So they told at least wait for 6 to 7 days time. So we kept with the second intra-aortic balloon pump from the opposite groin for the next 6 to 7 days. He maintained. And then we discussed with the family in detail that we need to go for the Impola supported rotablation for the superficial calcium and the shockwave for the deep calcium. And it's also one of the fact is when the artery is bigger, like left main, so rotablation is just goes superficially. Even with the biggest burr, 1.5 burr, 1.75, 2 millimeter, even 2 millimeter burr is not sufficient for the left main if there is a heavy calcium. Then in addition to rotablation, we need to have a shockwave. Shockwave balloon can be of bigger size, like 3.5 millimeter balloon. We can, and then by the 3.5 millimeter balloon, we can deliver the shockwave and break the calcium in the bigger vessel like left main. So this combination of rotablation and shockwave, the rota shock with Impella. So this time the family gave consent because they've seen as soon as they started weaning IBP, the patient was decompensating. There's no other option to take him out of ICU. Then we need to go for the revasc with the LV support device like Impella heart pump. This time family gave the green signal this time. This is the puncture, what we make in the right groin. This is the micro puncture needle with the ultrasound guidance. And then on the right panel is how we dilate that vessel. And then we put a pre-closure with the probe lights. And then this is a crossing LV with the right catheter. And next is the Impella wire is going. And this is the Impella device. You can clearly make out. This is the place of, this is the motor, which sucks the blood from here. And this pumps into the aorta. And thereby it maintains the cardiac output. Sucks the blood from the left ventricle and pumps into the aorta and maintains the cardiac output. And this is Impella CP. The Impella 2.5 liters is not enough for such an extensive disease with LV dysfunction. It's a 3.5 liter device, Impella CP. And once this device is there, your panel shows that cardiac output is maintained 3.5 liter. So whatever extensive work you want to do, you can do on this pump support. On the right panel, you can see the disease. How extensive is the disease? This is the, where is the mic? This is the distal left main here. There's a heavy calcium in the distal left main, which is extending into the LAD ostium and the circumflex. The heavy calcium. So the distal left main, this is the distal left main, which is looking whitish. This is the heavy calcium in the distal left main, which is going into the LAD and circumflex ostium. And there is one more lesion in the distal here in the circumflex. So left main bifurcation, LAD circumflex, and also in the distal circumflex at this point. And this is again the same panel. There's your distal left main bifurcation. Here heavy calcium. This Impella pump is there. And this is the cranial view. Also shows the critical left main distal lesion and also in the LAD. So this is about the procedure. This is going across the first left main to the circumflex circulation because circumflex is a distal disease. Wire across. But in a rotablation, what we do is we use a microcatheter with wire and we cross with the wire, advance the microcatheter, take out our workhorse wire and then put a rota wire. In this case, challenge was such a critical lesion. After going through the wire, the microcatheter was not trekking across the lesion because of heavy calcium, because of tight lesion, microcatheter was not crossing. So we had to take out the workhorse wire and put the rota wire itself directly. And then we started rotablating the lesion. This is the rotablation burr. This is a 1.75 millimeter rota burr. This was ablated left main to circumflex first, and then left main to LAD. In this panel, you can see left main to circumflex, and subsequently, we took that out and put it into the LAD. Now you can see the left main to LAD. Again, this is a 1.75 burr, left main to LAD, multiple runs. Once the superficial calcium is ablated, then we started with the fixing the distal circumflex lesion first. And distal circumflex was also very challenging because the whole of the circumflex was tortuous and a lot of calcium. So whatever balloon or whatever device you want to advance, it was not getting through. So we had to use a guide extension catheter just to allow the balloon to track into distal circumflex. And then we had stented the distal circumflex. This is the circumflex distal. So this is tackling of circumflex distal, the first stent. And then in the different views, we have confirmed the circumflex stent positioning. And this is how it's being deployed. The stent is expanding, and we have to put one more stent because there was some heaviness on the proximal part of the previous stent. And after fixing up the circumflex distal, we came to the left main bifurcation. We had already ablated with the rotablation. So now this is time for shock wave for IVL. This is the circumflex. Now it's IVL. The IVL is an intravascular lithotripsy. And this, you can clearly visualize, this is the balloon. This is the IVL balloon. This balloon has a 1, 2, or 3 emitters that emits the ultrasound waves. And those ultrasound waves, they break the calcium. And the aim is to break the calcium so that stent can expand fully. And that is going to decide the best outcome in the long term. So IVL was done from the LAD to left main and then through circumflex to left main. So whole bifurcation was taken care by the IVL shock wave. This is the IVL. Each cycle has a 10 pulses and total 80 pulses, means 8 cycles are there. So 3-4 cycle left main to LAD and the 3-4 in the circumflex to left main. And subsequently 2 stents were put. One stent in the circumflex, just 4 into 16 millimeter from circumflex to the ostrum of circumflex, and then one left main to LAD, that is a 438. So it was a mini crush, left main to circumflex, then final, the recrossing, kissing balloon, optimization, and this is the proximal optimization with 5 millimeter balloon of the left main. And now you can clearly see, this is the part which had a severe calcium. Now you can see the clearly expanded stent left main to LAD and also in the circumflex. This is left main bifurcation, which was mini crush. And it was optimized under ultrasound guidance, intravascular ultrasound. And how you see the images, you can see the vessel looks from inside. The stent, how stent is expanded. In the next panel, you can see the point of confluence. This is a barrel like one in the LAD and one in the circumflex. So it is very important because it gives an idea about how the stent is deployed and where you want to work extra. And this is how it looks like when you do a IVAS pullback. And there's a calcium 360 degree, or at some point at 270, and stent is well expanded. And this is very circular. That means stent is expanded very well. Well opposed, well expanded stent. And when you come to the bifurcation, it gives the idea about bifurcation. Yeah, this is the 8-shaped or double barrel. And this is the left main trunk, which is very well deployed stent in the left main trunk. Once you confirmed your optimal deployment, then you can finish the procedure. This is how it looks like in both the views. Yeah. This is a comparison. Here you can see the heavily calcified left main bifurcation. And this is after stenting of the 2 stents. And the left main bifurcation is taken care. You can clearly visualize. This is the left main bifurcation area, which earlier used to be the domain of surgeons. Left main body or left main ostrum used to be an interventionist, but left main bifurcation always used to be surgeons. Now it's a left main PCI after ablating calcium with the rota and then IVL shock wave, and then it's a bifurcation stenting and with the MPLS support because of LV dysfunction. And this is the MPLS being removed from the left ventricle. You can clearly see. And this is a checking groin. Whenever you use a large bore devices, like we do a MPLA with a 14 French, or we do a transcatheter aortic valve with a 14 French, 16 French, you need to check it by the check angiogram from the other opposite groin, whether you have closed the groin properly. So this was the ECG on very next day. This is the patient ECG. You can clearly compare with the previous ECG, which has got a wide QRS with the ST depression of all the precaudal leads, acceleration of AVR and V1. Now you can see the clear baseline ECG and all the ischemia has been taken care. Very next day, he started improving. MPLS support was weaned off on the day 1 itself. The same day of procedure, on table, MPLS was weaned off. The vasopressor support was gradually weaned off over next 3 days time. Day 3, all the vasopressors were off. Day 4, patient was mobilized. and shifted to room. Day 6, patient was discharged. Ejection fraction improved from 30% to 35 to 40%. MR reduced from moderate to mild. PA pressure came down from 55 to 35. And patient improved symptomatically, started, because it was very hard to see. His patient was very strong from inside, very positive, but he was not able to do anything. As soon as you remove the IVP, patient decompensates. So there was no other option. The creatinine came down to 1.5, and just 2 days back, the patient came for the follow-up, creatinine is 1.2. So the renal perfusion also improved with improvement in ejection fraction, improvement in PA pressures, reduction in the hematologic regurgitation. His cardiac output improved, and the renal perfusion improved, and the creatinine has also come down. So borderline creatinine is such an advanced age patient. There is a high risk of AKI or acute kidney injury, and patient needing for dialysis. So we had to take a consent for dialysis also. We don't know whether with such a dye exposure and such a long procedure you can have it. But the advantage of Impella is to maintaining cardiac output. It avoids the renal injury, maintains the renal perfusion. That is the second advantage of Impella. This is the learning point. It's an 85-year-old male with multiple comorbid conditions, long-standing diabetes, hypertension, CKD, stroke, LV dysfunction, critical left main, TVD with heavily calcified vessels, deemed inoperable by the cardiac surgeon. And complex PCI with rota or IVL or rota shock with Impella heart pump support has given new lease of life to the patient who was not possible to wean off from the intra-aortic balloon pump. And this is the last slide, is a take-home message. The complex coronary interventions for heavily calcified vessels, left main bifurcations, chronic total occlusions, post-bypass intervention, and LV dysfunction are common in a state-of-art cath lab these days. It requires a great teamwork of skilled interventional cardiologists, cardiac anesthetists, trained nurses and technicians. The teamwork is very important. You should have all skilled people with you, whether it's nursing staff or the technician, whenever you do a high-risk complex dose. And the cath lab should be equipped with all the equipments, like all the modalities for the calcium management, like rotablation, IVL, and also the imaging modality like OCT and IVUS, and also the LV support devices like IBP and Impella. Like we do have a console with Impella all the time with us. You can use it anytime. And case selection is of paramount importance. Like in America, they say AUC, or appropriateness use criteria, which a patient is suitable and which is not. So you have to justify your intervention on the basis of those criteria. So it's very important to have a good patient selection. And if you do a great work, you find the best results and with the least mortality. Thank you very much for patient hearing.
Very good. Fantastic, Sanjeev, for great presentation of type of cases which can be safely done. And that was the really highlight of the case, that nothing else, even balloon pump didn't support, and you needed to get to Impella and did a great job. Fantastic. And this is, I think, case example that patient who needs it, we can do it safely. So that basically the message, irrespective, it's a left main, low ejection fraction, whatever it is. But yes, after careful discussion with our colleagues, surgeons, and the family, we can proceed to take care of the complex blockages. And this was an excellent case, using various device synergy and, more important, imaging, particularly in the end, to improve the long-term outcome. Great case. And maybe we can take some questions from the audience if they have some any specific questions. I'm sure it's getting late for the dinner and drinks.
Yes, sir.
Thank you very much, Dr. Sanjeev. But my one question is, usually in diabetic patient, coronary artery syndrome is very common. And at the same time, CKD is also there, DKD, that is DKD. So usually creatinine is 4 to 4.5 and urea is also swinging around 200. Then in case the patient is coming to you as an ACS, what is your line of plan and how you can decide? Because most of the time they are telling that it should come below 2 creatinine for the dye and all. Otherwise, it is going to injure the kidneys and all. And permanent dialysis can be taken care of by that case. So how do you recommend the procedure further? Yeah. Thank you.
So ACS on the background of diabetic kidney disease with a creatinine of 4. So it all depends on how patient is presented. If it's an acute coronary syndrome with impending cardiogenic shock in a large area, jeopardy, we discuss with the nephrology team, and they always give clearance as a high risk case, and they take a consent for the dialysis if required. And we go ahead because the heart comes first. If it's an emergency, we have to go for coronary intervention. We have to do a diagnostic angiography and fix up the culprit artery after explaining the due risk of dialysis, if at all it's required. But these days, we have a minimal contrast or zero contrast PCI also. So we use a minimal contrast or some other imaging modality like intravascular ultrasound, in which we can minimize the contrast use and also hydrate the patient if the LV function is good. And thereby we can minimize the kidney injury. But definitely if the patient with ACS, with the impending cardiogenic shock, or the large areas involved, and if it's a STEMI, definitely we have to go for the revasc. If the patient is having stable coronary artery disease, like a chronic stable angina class 2 to 3, still we can manage the medications for the time being. But ACS, definitely we have to go for the intervention after taking clearance from the nephrologist and also consent for dialysis.
And that's another very important point. People believe that with the PCI versus Cabbage, that there is a less renal injury with the Cabbage versus PCI. You know, every trial actually have shown, as long as we are not repeating multiple PCIs, the PCI actually give rise to a less acute kidney injury compared to bypass surgery. All the trials of the complex PCI versus Cabbage, or for the TAVI versus the surgical valve replacement, all have shown the percutaneous intervention, we have less injury. But the case you described with a high creatinine, there's no other option. I mean, definitely that is the patient will belong to the cath lab, knowing that there's chance of dialysis or advancement of the renal failure and prolonged hospitalization. But that comes to the part of it, because at some point you need to make a decision whether we save the kidney or the patient. Yeah, if there is a mild, maybe just a low troponin, not much EKG changes, that patient probably can be managed medically or stabilized medically, not managed, maybe stabilized medically initially for a few days, and then make a call for invasive procedure. But otherwise, if patient having an evolving MI, irrespective of the creatinine, you have to take them to the cath lab.
I'm Dr. Sharma. Let me congratulate Shamim. It's a beautiful presentation. And what we have seen in last 30 years, there used to be a time just put a streptokinase, and let the patient to go home. And from the streptokinase, we have seen that the simple cases and complex cases, it's evolving. And we are proud to have such a wonderful team in our Jaipur city, who is catering to North India. And being citizen of this and have an excellent Dr. Sanjeev, we are proud to have this. I believe the creatinine is not a big issue, because with the dialysis it can be managed off. So, but the heart is an important issue. So we need not to get scared of the creatinine level. And the way India is, the South Asian population is a diabetic capital. India is going to a diabetic capital and having a more complex problems rather than taking as American population and all, or European. Basically, the South Asian population have a more bad disease, bad cholesterol, high calcium score. So I believe it's a beautiful time, and as the age grows over, the longevity is going on with other complications. So putting a quality of life is more important. So let me congratulate you, sir. Beautiful.
Very well said.
For curiosity's sake, I want to know how much time did the procedure take place? Is it as good as 𝐒𝐨𝐵𝐞 or more than that?
Yeah,
because you did a lot of complex things.
Yeah. It took almost 2 hours and 45 minutes.
But sometimes, as you know, the most of the cases are very short, less than 1 hour. But some kind of the case which Sanjeev showed with the impella, doing a bifurcation, then KISS, and then imaging, will take definitely upwards of 2 hours. And so, but key is the same, that you need to keep patient to, what happened many times when this long procedures, patients become very restless, very anxious. They start moving and they make our life a little difficult. So we try to keep, therefore cardiac anesthetist help is very of paramount importance, that keep patients sedated during the procedure. Because once we start the procedure, we do not want to cut short it for various other factors, then except some procedural issues are different. But by other extraneous factors, we do not want to cut short. And impella actually also help you in a relaxed atmosphere, try to do the better job. And that's where the trials have shown the cases where you use impella, you have a better long-term outcome in terms of lower revascularization and so.
So in the last case, in fact, left bifurcation didn't take more than 1 hour, but it was a left distal circumflex going across the toxicity and the calcium, they're putting a device across and with a guideliner, and every time you have to, even for the pre-dilatation, post-dilatation, putting a stand, and again, so it was a 45 minutes for the circumflex distal. So it took a little extra time. Otherwise, we would have finished it in less than 1 to 1.5 hours. So, yeah, any other comment, Dr. Kalla, please? So it was a very heavy rain this evening in the Jaipur, and all the roads were clogged with the traffic. It took almost 45 minutes for the 2 kilometers. So the multiple red lights and people were all stuck. Still, I could see the hall is totally full. So I'm glad to see, and I really like to appreciate their efforts and their energy to make it possible.
Clap for the audience, not for the speaker, clapping for the audience. Yes.
Yeah. Probably it was you as a factor, because everyone wanted to listen to you in person or you're through Zoom, but really enjoyed the evening listening to you. And we had a very good academic session. And I would like to thank Abbott team who has supported this event, and the Eternal Hospital marketing team led by the Nitesh. We had a wonderful time. And so final words from you side.
Well, I would just say, hopefully, making a premier institute with the getting the best doctors and the best equipment and the best management under leadership of Manju, my wife, and Dr. Prachish, and of course everyone, the top faculty. We are trying to deliver the best care, and key is that not need to go out from Jaipur to other cities for treatment. So provide everything possible with collaboration with Mount Sinai, if need to be, help of any expertise which is required. So that was always my dream, mine and Manju's dream, to make a hospital in our own city where it came from. Did from SMS Medical College, MBBS and MD, and then came here and provide that world-class service and a lot of support. Really thank all our Jaipur Vasis and of course Rajasthan Vasis to support this center. And we have kept it really to the highest standard of the national international level. Thank you.
This is the compliment from the audience is you've been maintaining your fitness. In fact, you're looking better and better day by day. So what is the secret of that?
Well, that's a lot of exercise. Continue. I tell everyone, continue exercise no matter what age you are. I just crossed 65 in May. You had to continue. Keep yourself fitness. Yes, we take care of others. You can take care of others only when you take care of yourself. Remember, I say slogan of the airlines that when oxygen mask drops, you put on yours before you put on even your kid or anybody side. So the same way that you keep yourself fit, then only you can deliver the care.
Yes, very true. Good, sir. Thanks very much for joining and making it wonderful. Thank you very much, sir. Thank you.
Bye-bye.
So with that note, we can proceed for cocktail and dinner. Thank you very much for joining and taking out your precious time this evening. Thank you.